Head and spinal cord injury. Spinal cord injury is usually a result of trauma. The four most common causes are motor vehicle collisions, falls, violence, and sports injuries. Neurological damage caused by spinal cord injury occurs in two phases: primary injury from the initial physical disruption of the spinal cord, and secondary injury from processes such as ischemia, hypoxia, hemorrhage, and/or edema. The major mechanisms of injury include flexion, flexion rotation, hyperextension, vertical compression, extension rotation, and lateral flexion. Flexion rotation injury is the most unstable because ligaments that stabilize the spine are torn. This injury most often contributes to severe neurologic deficits. Skeletal level of injury is the vertebral level with the most damage to vertebrae and related ligaments. Neurologic level is the lowest segment of the spinal cord with normal sensory and motor function on both sides of the body. The level of injury may be cervical, thoracic, lumbar, or sacral. Cervical and lumbar injuries are most common because those areas of the spine are associated with the greatest flexibility and movement. Injury from C1 to T1 can cause paralysis of all four extremities, resulting in tetraplegia, formerly called quadriplegia. The degree of impairment in the arms after cervical injury depends on the level of injury. The lower the level, the more function is retained in the arms. Paraplegia refers to paralysis and loss of sensation in the legs and can occur in spinal cord injury below the level of T2. The degree of spinal cord involvement may be complete or incomplete. Complete cord involvement results in total loss of sensory and motor function below the level of injury. Incomplete cord involvement results in a mixed loss of voluntary motor activity and sensation, and leaves some tracts intact. The degree of sensory and motor loss depends on the level of injury and reflects specific damaged nerve tracts. Symptoms, degree of paralysis, and potential for rehabilitation depend on level of spinal injury. Manifestations of spinal cord injury are generally the direct result of trauma that causes cord compression, ischemia, edema, and possible cord transection. They are related to the level and degree of injury. The patient with an incomplete injury may have a mix of manifestations. A loss of function is associated with each level of injury. Simply put, the higher the point of injury, the more function that is lost. The lower the level of injury, the more function is retained. At the C5 level, the patient has full shoulder control and can bend their elbows. This allows them to drive electric wheelchairs with mobile hand supports, and it also enables them to feed themselves with setup and adaptive equipment. They can actually do many activities of daily living by themselves with the use of adaptive equipment. They can even perhaps move themselves using an indoor mobility in a manual wheelchair. At C6, the patient is able to not only manage their own hygiene needs, but they can turn themselves in bed. They can also transfer themselves from a chair to another surface with the help of adaptive aids. The risk for skin breakdown, especially over bony prominences, in areas of decreased or absent sensation is a major consequence of immobility related to spinal cord injury. Pressure injuries can occur quickly and lead to infection and sepsis. So you see, by having the ability to turn themselves in bed, they can relieve the pressure on those bony prominences. Additionally, we need to also think about their risk of developing DVTs, or I should say VTEs. The venous thromboembolism is a common problem after spinal cord injury due to the hypercoagulability, the venous stasis, and venous endothelial injury. Immobilization promotes venous stasis and thrombi of the lower extremities. And detecting a DVT may be very hard in a person with spinal cord injury because the usual signs and symptoms such as pain and tenderness are not present. Again, having the ability at C6 to turn themselves in bed also improves their mobility significantly so as to avoid the common problem of venous thromboembolism. Cervical and thoracic injuries cause paralysis of abdominal muscles and often the intercostal muscles. The patient cannot cough effectively enough to remove secretions, increasing the risk for aspiration, atelectasis, and pneumonia. Hypoventilation and impairment of the intercostal muscles lead to a decrease in vital capacity and tidal volume. It is remarkable that when the thoracic injury is at the T7 to T12 range, then we have the added function and control of the cough reflex. So the cough is much more effective and is improved when the injury level is at below T7. T7 to T12, there are dramatic improvements in the ability to cough in these patients. This can make a very much a big difference in the patient's risk of any of these respiratory complications. In the first year following a spinal cord injury, the leading cause of mortality is pulmonary complications. Okay? Mostly because the patient has difficulty handling secretions with an associated atelectasis and hypoventilation. The weak or paralyzed abdominal muscles also preclude an effective cough. As we have mentioned earlier, vital capacity as well as tidal volume decline when injuries are at a higher level. When injury is at the lumbar level, we see return of movement, motor movement in the hips and knees. And then walking becomes a viable function with assistive devices. Patients here have good sitting balance, They have full use of a wheelchair and ambulation with long leg braces. They can become completely independent in ambulation with the use of canes and short leg braces, but they still are having difficulty standing for long periods of time. The return of reflexes after the resolution of spinal shock means patients with injury at T6 or higher may develop autonomic dysreflexia. Autonomic dysreflexia is a massive, uncompensated cardiovascular reaction mediated by the sympathetic nervous system. It involves stimulation of sensory receptors below the level of the spinal cord injury. The intact sympathetic nervous system below the level of injury responds to the stimulation with a reflex arteriolar vasoconstriction that increases blood pressure. The parasympathetic nervous system is unable to directly counteract these responses via the injured spinal cord. It most often presents in the chronic phase after spinal cord injury. Baroreceptors in the carotid sinus and aorta sense this hypertension and stimulate the parasympathetic nervous system. This causes a decrease in heart rate. Visceral and peripheral vessels do not dilate because efferent impulses cannot pass through the injured spinal cord. Autonomic dysreflexia affects approximately 90% of patients with spinal cord injury at or above the thoracic vertebrae 6, which is T6. Okay, so that's the magical number we want to remember. T6 and above puts this patient population at risk of developing a life-threatening condition called autonomic dysreflexia. It is a medical emergency. The most common cause is bladder irritation. Immediate catheterization to relieve bladder distension may be needed. Instill lidocaine jelly in the urethra before catheterization. If a catheter is already in place, check it for kinks or folds. If it is plugged, perform small volume irrigation slowly and gently to open the catheter or insert a new catheter. Stool impaction can cause autonomic dysreflexia as well. Also, remember to remove all skin stimuli such as constrictive tight clothing and tight shoes. Monitor the blood pressure often during the episode. If symptoms persist after the source has been relieved, give a rapid onset and short duration agent such as nitroglycerin, nitroprusside, or hydralazine, and carefully monitor until the vital signs are stabilized. Because autonomic dysreflexia does not occur in the hospital generally, it occurs once the patient goes home and can occur up to a year after the injury. For this reason, we must teach the patient and caregiver to recognize causes and symptoms of autonomic dysreflexia. They must understand as well the life-threatening nature of autonomic dysreflexia. They must know how to relieve the cause and to activate the emergency response system if needed. Since the spinal cord injury patient will likely be going home before they experience their first episode of autonomic dysreflexia, it is important that they understand the causes of autonomic dysreflexia and know how to relieve the causes. For a patient at risk for autonomic dysreflexia, these are some of the information that we must put in their teaching plan for both the patient and caregiver. Signs and symptoms they should recognize: a throbbing headache or the sudden onset of an acute headache, elevation in blood pressure and reduction in pulse rate, flushed face and upper chest above the level of the injury, and pale extremities below the level of the injury, sweating above the level of injury, and goosebumps below the level of injury. They may also experience other symptoms such as blurred vision, a feeling of apprehension, and maybe even nasal congestion. With autonomic dysreflexia, we see two different presentations, one below the level of injury and a different one above the level of injury. So as we see in the picture, above the level of injury, there is vasodilation, so that the patient looks flushed and they're warm and diaphoretic. And below the level of injury, we have vasoconstriction occurring. And in this case, we have the hypertension, the pallor, the goosebumps, all present. So the level of injury causes a different presentation below and a different presentation above. While it is important that the patient and caregiver can recognize the symptoms of autonomic dysreflexia, it's going to be even more important that they learn how to treat the symptoms, how to relieve the cause, because it is life-threatening. The aspect that is life-threatening is the high blood pressure. So the severe hypertension that accompanies autonomic dysreflexia is what can lead to a stroke. This is the most common reason for the demise of these patients from autonomic dysreflexia. The blood pressure gets so high that they have a stroke. Acute management of autonomic dysreflexia. Autonomic dysreflexia is a life-threatening condition, and thus it requires immediate resolution. Okay? This is not the time for the nurse to do further assessment. It is not the time for the nurse to search for the cause of the autonomic dysreflexia. Instead, we need to intervene because the patient is in distress. How can we lower their blood pressure, since that is what is going to kill them? Well, that's pretty simple. Elevate the head of the bed, change their position. We can lower their blood pressure by elevating the head of the bed, as well as dangling their lower extremity over the side of the bed. Okay, this will mean that more of the circulating blood volume is, what I like to say, out there. Less is returning to the right side of the heart. We have decreased preload, decreased cardiac output, which decreases blood pressure. So simply intervening at this point to lower the blood pressure would be the priority action. We can determine the cause later, and we can also then notify the healthcare provider, but not until you intervene first. Given the life-threatening nature of autonomic dysreflexia, the nurse should perform measures to decrease the incidence of autonomic dysreflexia, such as maintain a regular bowel function, to monitor urine output, And also to teach the patient to wear a medic alert bracelet, indicating that they do have a history of risk for autonomic dysreflexia. Know that there are studies and scientists working on devices that will improve a patient's quality of life who has a spinal cord injury. One of these that they are working on is called the sacral anterior root stimulator. The device or the handheld control is outside of the body, but the actual stimulator is surgically implanted. And this will then allow the patient to control their own bowel and bladder movements with the press of a button. Okay, so this is wonderful for controlling bladder evacuation, and it's really good also for improving their bowel management. In terms of improving their quality of life, you can imagine that this is huge, and they don't have to depend on anybody else to do these routine activities of living. But what it really does, and why it is so consequential, is the fact that we eliminate the risk that they have of getting autonomic dysreflexia. Because if you can make sure that the bladder is routinely voided and completely voided, then you decrease the risk of urinary retention, of bladder infections, and overfilling of the bladder, all of these things that could be a trigger for autonomic dysreflexia. So we do have a lot of ongoing research to come up with devices that can improve their quality of life, but not only that, could even save them from a life-threatening condition that we call autonomic dysreflexia.